Good morning, everyone. Welcome to the webinar. I will be introducing the speakers. First, I will introduce Michael Ruppel, then followed by Carl Schmidt. Michael Ruppel is the Executive Director of the AIDS Institute, a national HIV/AIDS organization with a mission to promote action for social change through public policy research, advocacy, and education. The AIDS Institute program and administrative offices are in Tampa, Florida, at the University of South Florida, College of Medicine, and the National Policy Office is in Washington, D.C. For the past 15 years, Michael has functioned in senior management from the nonprofit sector, developing, managing, and providing HIV/AIDS support services in various capacities, including case management, supportive housing services, rental assistance, food pantry, financial management, and job placement. Prior to his experience in the nonprofit field, he worked as a real estate construction lender for Barnett Banks of Florida. He founded and owned a real estate company as well as a real estate development and construction company for over 12 years. As a licensed real estate broker, mortgage broker, and residential contractor, Mr. Ruppel has an extensive background in financial and business management and program and project development. Since transitioning into the work with HIV/AIDS service organizations, he has developed and supervised advocacy and outreach programs, research projects, prevention services, food service programs, comprehensive financial assistance services, direct housing and housing assistance programs, volunteer programs, special events, and fundraising services. Carl Schmidt was named Deputy Executive Director of the AIDS Institute, a national public policy advocacy and research organization, in June of 2009. Prior to that, he served as the Institute's Director of Federal Affairs, a position he held since February 2004. Prior to joining the AIDS Institute, he served as a consultant to a number of HIV/AIDS and civil rights organizations. He has worked in Washington for over 20 years and began his public policy work in the energy arena, which continued through 2003. Mr. Schmidt is co-convener of AIDS in America, a coalition of national AIDS organizations that focus on federal HIV policy, co-chair of the AIDS Budget and Appropriations Coalition, a convening group member of the Federal AIDS Policy Partnership, and co-chair of an HIV testing reimbursement work group. He is former chair of the HIV Prevention Action Coalition and the Ryan White Reauthorization Work Group. He remains active in those coalitions, along with others that advocate for Medicaid, Medicare, and health reform, the AIDS Drug Assistance Program, and hepatitis issues. He was a member of the Presidential Advisor Council on HIV/AIDS from 2007 to 2009 and chaired its domestic subcommittee. In 2010, he was named by Pause magazine as one of the 100 most effective AIDS fighters in the nation and was recently named by Whitman Walker Health as one of 25 individuals who have played prominent roles in the fight against HIV/AIDS in D.C. over the past 25 years. Mr. Schmidt earned a BA in Public Affairs and an MBA in International Affairs from the George Washington University in Washington, D.C. So we're honored to have Michael Ruppel and Carl Schmidt present to us an HIV/AIDS and the ACA federal and state policy update. Michael, I turn it over to you.
Thank you, Dr. Beal, and we want to thank the Florida Caribbean AETC for having us present today. Sorry, I lost my screen. The AIDS Institute works on many issues impacting HIV and AIDS in the hepatitis communities. And many of these issues we are covering today could easily be standalone webinars because the subject matter has so many complexities. But what we've done is identified some top-line issues, and we'll cover those briefly with you today. So we've broken it up into two parts. The federal update, which Carl will provide to you, and we'll cover budget and environment, recent funding levels for HIV and AIDS programs, and then implementation of health reform, which is obviously important to all of us. And for the state of Florida update, the state budget process, the pending legislation that we have going right now that impacts our community, and then changes to the HIV and AIDS healthcare infrastructure. So those are the issues that we will be covering, and I'm going to turn it over now to Carl Schmidt, our Deputy Executive Director.
Well, thank you, Michael, and good morning, everyone. So first, the current budget environment. And to begin that discussion, I wanted to first show you what the federal budget looks like. This is actually the expenditures. And it totals around $3.5 trillion, and that's actually down. It used to be $3.7 trillion a couple of years ago, and we'll talk reasons why it has been reduced. But if you look at the spending, it is divided into mandatory spending, which is Social Security, Medicare, Medicaid, and other mandatory programs, and then discretionary spending, which is divided into non-defense discretionary, and that's where the programs that fund health programs that will be focused on are, and then also defense spending. And I would say how this has changed over the years is the non-defense spending has gotten smaller, and there's really been no change to the mandatory spending. And then, of course, we have interest as well, because our government at the federal level operates at a very substantial deficit, and debt, carries a lot of debt. And that has led to some changes to how programs get funded here in town. So the next slide, it talks about the historical revenues, receipts versus expenditures. And the orange line is the expenditures, the blue line are the receipts. And you can see that our federal government for many, many years is operating at a huge deficit. And in around 2010, 29, you can see the deficit was $1.4 trillion. That, if you look at the receipts, it's only $2 trillion. So, that is an awful lot of money that we are operating with in the red. And this is a trajectory that, is really unsustainable. And there were some election changes here in Washington. There's a revolt around the country. I'm sure you've all heard about the Tea Party. And things, changed up here. And people said, we cannot continue to operate our federal government in this way. And, it's cumulative, the debt. So in 1 year it's $1 billion. Well, you still have the debt from previous years and growing debt. And in late 2013, we had a cumulative current debt of $17 trillion. And you have to pay interest on that. And it keeps on growing and growing. And you can see it's even projected to, grow now, even though we're trying to get a handle on expenditures versus the revenues. So because of this new Congress and this huge deficit, there was an agreement between the Congress and President Obama, and that was with the Budget Control Act of 2011. And they agreed to cut the deficit by $2.4 trillion over 10 years. In two different ways. They would discretionary spending caps would save $917 billion over 10 years, and then they created a bipartisan super committee made up of members of the House, the Senate, and both parties to identify an additional $1.2 trillion in cuts. Well, that super committee failed to reach any agreement because there's just partisan gridlock in Washington, and therefore sequestration, which we've all heard about, began. And so this began in 2013. It was an automatic cuts had to be taken across the board, equally divided between the defense and non-defense discretionary programs. Notice that the way they are taking the cuts, it's not going to the largest part of the pie of federal spending, the mandatory spending, but really focusing on making those cuts. No one ever thought it would occur on the defense and non-defense discretionary programs. So $80 billion in 1 year, So that amounted to around 5% cuts to those programs. And when you translate that down to domestic HIV programs, it was around $380 million cut in 1 year to our programs. And these were set to continue for the next, until 2021 if there was no change. And so you would get your $1 trillion in savings. Well, there was great opposition to sequestration. Obviously, the AIDS community was opposed to it, but defense communities were opposed to it. Everyone was opposed to sequestration because it was taken across the board equally, no matter if it was a program that provided drugs, life-saving drugs to people living with HIV, or any other program of the federal government. So there was great opposition to the sequestration. So brings us to this last year. The House, which is controlled by the Republicans, and the Senate, controlled by the Democrats, had very differing views about how the total budget should be allocated and at what level. And they couldn't reach any agreement on the total budget and then on the individual spending bills. Most, wanted to replace the sequestration. I think that was across the board. But there were wide disagreement on spending totals and how to cut the budget. And at the end of last year, in October, because they couldn't pass a budget nor the spending bills or a continuing resolution to keep the government open, it resulted in a shutdown of the government for 14 days. And we have not seen that in over a decade. It was basically, government, it was at an impasse, and our leaders couldn't come to any agreement. Well, after this, there was a compromise reached by Senator Murray, who heads up the Budget Committee in the Senate, and Representative Paul Ryan, who heads up the Budget Committee in the House. And they agreed to increase the budget caps for both fiscal years 14 and fiscal years 15. And that part of the sequestration cuts would be replaced, and it would be paid for by mandatory savings in non-tax revenue. So that's where we find ourselves right now. We're operating under those spending limits last year and this year. And because of that agreement, the spending bills were able to pass. And now I'm going to talk about how this has played out at the individual program level, looking at prevention, the Ryan White program, AIDS housing, and AIDS research at the NIH. And I have to say, throughout all of this, even though we were victims of the across-the-board sequestration cuts, HIV/AIDS programs did fairly well compared to other programs in the federal government. So let's first take a look at CDC HIV prevention programs. Starting in FY 2011, it was around $800 million. And actually, we got an increase in FY 12. It's, domestic HIV programs have been a priority of the Obama administration, and with the National AIDS Strategy and its goal to decrease new infections. But because of the sequestration in FY 2013, HIV prevention programs at the CDC were cut by $45 million. And so that, was across the board and had impacts throughout the country. But then with the budget agreement of FY 2014, we were able to make up for some of that money, and it was increased by $20 million. And the President has proposed to increase HIV CDC spending by an additional $4 million. The goal now is to make sure that we get those increases. But you see, we are operating with less money than when we had in FY 11. Now turning to the Ryan White program, and you'll see the same trends. FY 11 we had an increase. FY 12 we had an increase mainly to the ADAP program. Both those years actually were to the ADAP program because of the severe wait list, which Florida is very familiar with. But because of sequestration, the program was cut by $143 million in 1 year. with the budget, Balanced Budget Act of the Compromise in 2014, we were able to restore around half of that funding, and then the President has proposed basically stable funding for FY15, a slight increase, which we'll talk about in one program. So turning to, I just gave an overall Ryan White program historical funding, but this is what it looks like if you look at different parts of the Ryan White program. And Part A and Part B have basically been stable. You see there was a small decrease in FY12 to Part A, a slight increase for Part B base, and that was because of the some TGAs were no longer eligible to receive funding, and that was transferred to Part B funding. You can see that we've got an increase to ADAP, small increase to Part C as well in FY12, but you can see in FY13 every part of the program was cut, including ADAP, and those gains that we tried to basically erase the gains that we had in the ADAP program for FY12. Now, if you look at FY14, a lot of those, half of those cuts were restored. And then if you look at FY15, you can see basically flat funded every single program except Part C and Part D. And that's what I'm going to talk about next. So the President is basically proposing to flat fund the Ryan White program, no increases, except he's proposing to defund all of Part D, transfer that money to Part C, and give them a $4 million increase. So the reason for that the administration is proposing this is done in the name to reduce paperwork and reporting. The President is saying in HRSA that 67% of Part Ds also are Part Cs, and they have to file paperwork for applications, reporting, and it's duplicative. And so they are proposing to totally defund Part D. Well, that may be a good intention, but the services of Part D are very different than the services of Part C, along with as everyone knows, Part D funds women, children, youth, and families. And there's no guarantee that when you combine the funding for Part C, all that funding Congress will go along with it. They may say, oh, this is a signal that we could cut the program. And even though there's a lot of Part Cs that do get Part D funding, there is no guarantee that they'd like to receive that funding, and they have different needs for those dollars. There's no guarantee that they're going to get that money in the future. And it really appears to be a reauthorization move, a way to reauthorize the program, change the program, not going through the authorizing committees, but through the appropriations process. And there seems to be strong community opposition to this proposal, and we're not sure that the Congress is going to go along with the administration's proposal. Now looking at NIH research, some cuts, as you can see, some minor increases, and the President has proposed to basically flat fund the program. And HOPWA, the same thing. We've seen some decreases there. Big decrease with in FY13 with the sequestration. Half of it was restored, and the President is proposing to increase the funding for FY15. But you can see it's still not going to be at the level of FY11. So what to expect for FY15? It is a very status quo budget. When they agreed to the funding levels for FY14, they also agreed to the funding levels for FY15 overall, and they're basically very similar. Right now, advocates are fighting to maintain the current funding levels. It would be great if we could get increases, but in this environment, it's going to be very difficult, and we're really fighting to maintain the programs and make sure they're not being cut. The House and the Senate come up with, they have different philosophies, and the House will come in with much lower numbers for health programs, and the Senate will be much higher. It will result at the end of the year in a compromise between the two. And, as we go up to the Hill, we're hearing a lot about, what is the impact of the ACA on the Ryan White program? Is this going to save the program some money? And so that is the biggest question that we get and that we answer on the Hill, that we need to defend the Ryan White program. So now turning to implementation of the Affordable Care Act. I think everyone knows it was a slow start, but a very strong finish with the enrollment. And the impact on the HIV beneficiary is really dependent on the state, if there's a Medicaid expansion or not, and also the state's ability and willingness to transfer and get ready, for the Affordable Care Act. I think I heard NASDAQ yesterday report as of March 1st, around 10,000 people, states helped with enroll people in the expanded Medicaid program nationwide living with HIV, and around 5,000 or 6,000 were enrolled in the marketplace. And but that does not account for the last month. And Medicaid expansion is enrollment is throughout the year, so we can see those numbers climb. I think our eventual goal is to bring more people with HIV into care and treatment through combination of the Affordable Care Act and the Ryan White program. But the short-term goal is to transition Ryan White clients and provide coverage completion services to people living with HIV. Implementation is going to take time. I think we could learn from the first year and improve and be ready and do a better job for next year. But right now, for the Ryan White program, one of the first things that they can do is to pay premiums and co-pays. And we saw that some plans refused to accept them, and there was a court challenge. We had great support by the Obama administration, and the Centers for Medicaid and Medicare Services issued a rule which required plans to take Ryan White programs. And then if you're looking at the individual plans, we did a review of how they treat HIV and hepatitis drugs, and we found that several plans place every HIV and hepatitis drugs on the highest tier. And this is, we feel discrimination, something that is against the law in the Affordable Care Act. So we may pursue some complaints there. And we're finding with these high tiering is high co-pays, use of co-insurance, and high deductibles. The co-insurance is something that we are seeing more. 50% the patient, the beneficiary, would have to pay. And we don't know, the patient doesn't know what that 50% is. Usually people are used to paying a co-pay of like $50, $40, $150 at most. But we're finding patients are, 50% co-insurance could add up to maybe $1,000 a month. And then we're also finding limited formularies. A lot of the plans are not covering the single tablet regimens. And then we're also finding maybe the physician networks don't cover Ryan White providers. So those are some of the things that we're going to have to deal with as it's implemented. We're also looking at the future of the Ryan White program. We need to analyze the impact of the Affordable Care Act through studies and data. But I think we also have to realize that we need to continue to provide the coverage completion services for the 72% of clients who already have some form of coverage, such as traditional Medicaid or Medicare. And we need to determine the cost of paying the premiums and the co-pays. No one knows how much that's going to be. And we need to determine the level and cost of the coverage completion services that the Ryan White program provides. Some plans benefits are better than others, and we need to provide the services to achieve viral suppression. And we need to account for the people not covered by the ACA. People who are undocumented, people who have been in the country legally for less than 5 years will not benefit from the Affordable Care Act. And what about all those states, such as Florida, that are not expanding Medicaid? We still have to provide the Ryan White program for them. This is just a little chart that we use from the CDC Medical Monitoring Project that looks at the support services that are provided in Ryan White-funded clinics versus non-Ryan White-funded clinics. And you can see that they are much higher for like dental, adherence counseling, risk reduction counseling, case management. These are all the things that the Ryan White program provides that are necessary to have viral suppression. And we could look at the ADAP expenditures in Massachusetts as an example that has Medicaid expansion and healthcare reform, that they are basically using their money now less on full payment of drugs, but more on co-pays and premiums. And at the same time, with about the same amount of money, they've doubled the number of patients that they are seeing. So we hope to repeat that throughout the country. And hopefully, you know, everyone knows the treatment cascade, that we hope that we can, with the Affordable Care Act and the services of the Ryan White program, we could see an improved treatment cascade for states such as Florida and throughout the country as well. So now I'm going to turn it to Michael, who is going to give an update on Florida.
Thank you, Carl. So, the Florida legislative session, we are already past the midway point. April 22nd will be the 50th day of this legislative session, and it's also the last day of the regularly scheduled committee meetings. So we have a lot of work to do in the remaining time that we have left with these committees. May 2nd is the 60th day of the regular session, and that is also the last day. So a lot of work that needs to get done before then. So we're going to talk about a few things that we are monitoring and certainly should be of interest to you. Both the House and Senate have passed their budgets. The House being $75.3 billion and the Senate $74.9 billion. So, you know, based on those dollar amounts, they're fairly close. And the reconciliation of those are done through a budget conference. And that was supposed to begin last week, and this week with a break, they are not meeting, so we anticipate it happening next week or beginning that process. So both budgets provide at least $500 million in tax cuts, and there's about $1.2 billion in budget surplus. And that's where the budget conference would come in and reconciling those two so that, one, we have a balanced budget, and two, the House and Senate are the same amounts moving forward. There's no legislative meetings this week due to the holidays, but they will pick up again on Tuesday. The Senate President's already named his budget conferees, and what I've listed there is the health conferees, which is obviously the members that would focus on the majority of the programs that we are concerned with. And we've already met with all of these folks, and we're beginning to provide additional materials and respond to questions as they're asking for them. So the governor's budget, the House budget, and the Senate have included no increases, but then no reductions in the AIDS Drug Assistance Program or the AIDS Insurance Continuation Program. That is good news and bad news. And the reason we're specifically highlighting that is because in Florida, our general revenue does contribute to those programs, and has over the past a few years. And in fact, last year, $2.5 million in general revenue was added to the AIDS Drug Assistance Program, and that is a continuation and will be continuing and is in this budget. So the AIDS Institute is advocating for an additional $1.7 million in general revenue to restore the hepatitis funding back to 2009 levels. Those cuts in 2009 were not due to the program, but because it was general revenue, the amounts were rolled up into other programs. And when those other programs were included, or cut from the hepatitis was negatively impacted by it. So what we're trying to do is have those dollars restored to those funding levels. And our proposal is to assure that the 15 counties that are currently receiving funding for hepatitis have sufficient funding for at least one more dedicated FTE, and then additionally expand for 10 counties that are not currently participating in the hepatitis program, and then provide supplies and materials to support these programs. Both the House and Senate have included additional almost $14 million in federal budget spending authority for ADAP. We've received quite a few calls when the budget first came out, thinking that that was $14 million in new money. It's just budget authority, not knowing what the federal appropriations levels will be and what the award will be for Florida. They have to estimate what they think it will be and provide that budget authority to the Department of Health so that they'll have that leeway to be able to spend those dollars if the federal program funding comes through. Right now, there is an additional $100,000 for hepatitis C testing and diagnosis in the Senate budget. And why is this important? It is important because, one, our advocacy has created a lot of information sharing with the legislators. We were surprised, actually, that they were hungry for the hepatitis information, especially around hepatitis C, and they've asked for more information even throughout the summer. But this also means that they are taking this proposal seriously, and that they want more information in the field. They want the Department of Health to have more infrastructure to be able to get this education and information out to the communities. It's also an opportunity for that to be a placeholder. As I had said earlier, there's additional surplus dollars in the budget. So through the conference committee, we would like to advocate for that additional $1.7 million that had already noted, and this placeholder of $100,000 could be increased to that through that process. So now we're going to talk about some pending legislation that we feel would be of interest, certainly to you. And it's legislation that we're working on and we are also monitoring. And I've included in there the links to the Florida Senate and Florida House. And the main reason I'm including that for you is if you don't do this already, go to those websites. They're really well organized. They're easy to maneuver. They're easy to find bills and what the activity of those bills are. You can also set up automatic alerts to send you information if there's changes to any of the legislation that you're trying to monitor. But they are great websites, and you can also get some of the information that I'm providing here for you. But I've extracted what may be of interest, especially around seeing your legislator listed. And so if you wanted to provide comment to them and add your voice as additional support for this legislation, of course it's always important that they hear from their constituents. So the first bill we're going to talk about is the hepatitis C testing. And this is to test persons born between January 1st, 1945 and December 31st, 1965. This is a CDC recommendation, and there was nothing in Florida that encouraged providers to do that. And the sponsors of this bill, Representative Mia Jones, and the Senate sponsor, also decided early on that they wanted this to be a mandate. And unfortunately, through this process, the mandate to physicians to do something has been a problem for the medical associations and some individual doctors and physicians and providers that do not support mandates. And on the flip side, there's been a lot of support and following the CDC recommendations and moving forward with some type of a system that gets these folks tested in Florida. So far, this bill has done very well in its committees. It stalled recently, again, due to that mandate, and the sponsors are looking for other opportunities to possibly amend other bills to keep this legislation alive. And they're also even discussing the possibility of reducing or removing the mandate completely. So the other small barrier that's been attached to this, and I say small meaning that it's one hurdle to address, and that is a cost impact, because any bill that's put forward in Florida has a cost assessment done, and what will be the impact of the state if this bill is passed. And there was a cost impact from the Department of Corrections that was put forward, and that there is some dispute over what those dollars look like. So that has slowed the process of this particular legislation. The next piece of legislation I want to talk about is the HIV testing. We've had testing statutes for many years, and this is basically changing the wording of our testing language to, in the simplest terms, to be, rather than an opt-in test where the patient has to basically ask to be tested for HIV and then be informed of all of their the issues surrounding the HIV testing and their risk factors, to an opt-out testing, meaning we're trying to encourage providers to offer the test, still provide an informed discussion with the patient at the time that the test is being offered, and allow the patient the opportunity to opt out and say that they would prefer not to have the test. And if that's the case, it could be documented in the file. With everyone except for pregnant women. A few years ago, there was a advocacy movement to have all pregnant women tested for HIV, and that still is the case in Florida. They do have the opportunity to opt out, as well as in this change for HIV testing, but that opt-out would have to be in writing. And that would continue to be even if this legislation passes. It's done very well. It's passed all of its committees in both the House and the Senate. And it has additionally been added to another bill that was moving forward as another opportunity for it to ensure passage. The next bill that we're watching, and many of you have probably heard, the Syringe exchange program. It went through the legislative process last year and did very well. This is a program that was developed by the students of the University of Miami College of Medicine, and this year when they came back around based on feedback from legislators, they changed the name of the legislation to the Infectious Disease Elimination Act, or the IDEA bill. And it creates a sterile needle and syringe exchange pilot study in Miami and Dade County. And that's important because the original bill that was originally presented last year was for the entire state of Florida. And this is to create a pilot study. It's done very well again this year, and looks like it will be going to the floor for a vote. And as you can see, I've listed the bill reference numbers and the sponsors for your reference. The next piece of legislation is the Patient Access and Continuity of Care bill, and this is, in the simplest terms, to reduce barriers for providers to be able to get medication to their patients. So, eliminating or streamlining step therapy, eliminating fail-first policies that require that providers try X regimen prior to another one that we know or may know is more effective, and streamlining that process and the authorization process to make it much faster and easier on the provider. Getting it approved, which means ultimately the patient is going to have the care that the provider initially wanted and at a much faster pace. There has not been a lot of activity on this particular legislation, but we are still monitoring it and will be next week when the session starts again. So we've all heard about Medicaid expansion as part of the Affordable Care Act. Has not done well in the political environment in Florida, and we don't anticipate it's going to do well again, but there is some activity within the legislature this year, at least talking about it, but there is no optimism that anything is going to happen. But I mention it because you don't hear a lot about it on the news as you did last year. The Florida KidCare legislation would allow children of legal immigrants who have lived in the U.S. for less than 5 years to be eligible for KidCare. That's just an expansion of that program to ensure that those kids are being taken care of. And moving on from legislation, we want to talk about some changes to HIV and AIDS and healthcare in Florida, things that would impact the way we function. And one of the emerging issues is the Rule 64D changes as proposed by the HIV and AIDS patient care programs within the HIV and AIDS and hepatitis section. The majority of the rule change, which is a process to changing Florida rules, they held public hearings throughout the state to get feedback, and they also took written comments if you weren't able to attend one of these hearings. And that process is normal for any rule change. What's unique about this and the reason it's an issue is there were some proposed changes that were of concern certainly to providers and advocates around the changing the definition of the qualifier for these programs, one of being that the person would have to be HIV symptomatic in order to begin access to or receive baseline access to these programs, including ADAP or the AIDS Insurance Continuation Program. This was obviously a concern because we know that data shows that early treatment is much better for the patients. We expect that final rule should be released in the next few days, and then there will be a public comment period for that final rule before it's actually implemented. So you should watch for that notice to comment on that when we'll be putting it out, and a lot of other groups will be putting it out too. So the Affordable Care Act and Ryan White, and you heard from Carl what's happening at the federal level. And in Florida, there were a lot of issues around the Affordable Care Act and its restriction in being implemented in Florida because our leaders didn't want the Affordable Care Act. We didn't want Medicaid expansion to happen, and contrary to the community's beliefs. So we had to create systems to wrap around a program that really wasn't publicly acknowledged. So it made this first year of enrollment very hard to wrap our hands around it. And some of those things, we'll talk about in a second. But the Ryan White programs, including ADAP, are still needed. And we have to have coverage completion. We have to be able to assist clients with out-of-pocket costs and to keep them in their plans and to keep them in treatment. So the Florida ADAP and AICP program have transitioned some clients already into marketplace plans, but not very many, and not as many as we anticipated. If we were going to be talking about this last September, we were very hopeful that we would be able to move patients into this new system, and for all of the reasons that you've heard and problems with the ACA, there are a few others that have created barriers in Florida that were unique and made it tougher for us to move people out of a stable program into one that, in our opinion, in many opinions, was unstable and had too many unknown factors. So the next enrollment period for the Affordable Care Act is November 15th, and between now and then, the Florida Department of Health is going to be working with the community and a lot of advisory groups to develop a system that provides that wraparound support with Ryan White. So that's something to be not only watched for, but something you could be involved with at many levels. So this snapshot is really provided to you as a link. It's the analysis of the silver plans that Carl referenced, and that our DC staff spent a lot of days and a lot of time on to see what the impact of these plans were. And in this, going through this process throughout the state of Florida, this is how a lot of gaps were identified and some of the problems that Carl had referenced. So if you use that link, you'll be able to download that Excel spreadsheet, and if you haven't seen it before, get a lot of information about the plans and the analysis that we did. Quickly, I want to talk about the Florida Medicaid Managed Care Program, and mainly because there is so much confusion about the Affordable Care Act and Medicaid expansion as part of the Affordable Care Act. This managed care expansion is Florida's Medicaid program. It's moving to a managed care model. It was an experiment, a trial period that has been done over many years in a couple of different regions in Florida, and now it's going to be the statewide norm. But it's not going to happen overnight. It's going to be rolled out this year. And this in itself is a good example of a webinar that could be done completely independently. And there's a lot of information that needs to be provided. Patients are receiving letters already about their enrollment and how they enroll. But this does not impact the PAC waiver program. But it does impact others in Medicaid. And they need to pick a plan. Now, there is misinformation out there about whether they have to be in a HIV and AIDS specialty plan. Unless that is the only plan that's offered, that is not the case. They don't have to pick a specialty plan, but certainly in most cases, that's probably going to be the most beneficial. This is just a snapshot of the region maps if you don't have it or not aware of it, but it will provide you the link to get this information and how the managed medical assistance program works. There's lots of information on this website, and this is the link for it, where it will provide you this program overview, snapshot, and these are the rollout dates. So in May, there's 3 regions, and it's going to be, again, rolling out throughout the year. And we will be hosting, the AIDS Institute will be hosting specific webinars with the Medicaid office on this information specifically, and information for patients and providers on how this is happening and what they need to do and be able to respond to questions. So last thing I want to wrap up with are some changes to the Florida Department of Health that impact us as a community. And the HIV and AIDS and Hepatitis section is moving its contract unit to Central Contracts Management. It's always had, even when it was a bureau, it had its own contracts unit, so they're centralizing that. The hepatitis program is going to be joining STD section, moving out from HIV and AIDS. So there's potential programmatic impacts and certainly some policy implications there that we will have to monitor and address. And then there's going to be a new HIV and AIDS administrator, Sherry Riley, who probably most of you know or have heard of. Will be retiring at the end of this month, and so we'll have a new administrator that will be running that section, and that will be important because it's yet again more institutional knowledge that we are losing from the program, and after 36 years, we do wish her well, but we will miss her experience and her abilities. And that's all I have today, Dr. Beal.
All right, Michael and Carl, thank you very much. That was a wealth of information, expertly presented, and we appreciate this tremendously. For everyone on the call, I would like for you to know that the session has been recorded, and the audio and the slide presentation will be available on a link on our website within the week so that you can share this seminar with others and advise them at the bottom of the question and answer slide that they can go to www.fcaetc.org and they would be able to access and view this seminar. We also will be having the next ACA seminar on May 14th, 2014, so mark that date, May 14th, 2014. And LR, who had asked a question about will information be available on the territories, we have a goal of being able to provide information related to ACA and the impact on the islands of Puerto Rico and the United States Virgin Islands as a part of that next session. You see speaker questions and technical assistance support issue area on the right, to the right of the slide. Please, if you have any specific questions, go to your computer screen and type those in now. And I will go ahead and ask Carl or Michael, will one of you talk about how important it would be for us as clinicians, providers, nurses, case managers, how should we let individuals know regarding the Affordable Care Act and transition of difficulties that might be experiencing, especially if they are any gaps in services? What mechanism do we have in our state for addressing this?
Well, this is Michael. And in response to that, Dr. Beal, thank you. The AIDS Institute is currently working with AETC to put out a digital survey to gather information not only from you but from your colleagues, from patients, from people around the state to collect information about these barriers that people have had, or even if it's reasons why people didn't look at the Affordable Care Act as an option for them. So it's important, as Carl's mentioned before, that these barriers are identified and then put in front of the administration and the appropriate people so that changes can be made. And some changes have been made because of that. So if you don't tell us, if we don't know about it, then they don't know about it, and we can't advocate for it.
And I could answer what we do with it then at the federal level, because obviously we can only do what we hear, what's happening on the ground. And so we are in frequent communication with the Ryan White, program up here at the federal level, and also we have periodic calls with the administration, the CMS, and we just had a call with them on Friday with some of our colleagues across the country, asking, how is it going? I think the biggest issue we had was this high copays. And then frequently there's meetings at the White House with patient groups, and then we have a mailbox that we can submit issues to as well. So it's important to get those on-the-ground experiences and problems to help shape, as Michael said, the next year, because we just completed the first round of the plans, and they could change the plans for next year, and with increased premiums, changing the deductibles, and we want to make sure that they are changed in a positive way for the patients.